Today I'll discuss tennis elbow and how repeated movement testing can be used to determine if you actually do have tennis elbow or tendinopathy or lateral epicondylgia, or you have an elbow joint derangement or something else. And I was going to be brief, but then I just started writing more and more information because these bits of information are actually really important to understand, because I'm asking people to think very differently about how the musculoskeletal system works. Because I know what I was taught and what most people still subscribe to is that almost all elbow pain and maybe knee pain and heel and Achilles pain is due to a tendon, or at least the large majority of it is. And I don't find that. I don't find that when I use repeated movement testing as part of my orthopedic evaluation that all these things are tendon generated problems. So I encourage you to look at the online article. It's free. It's not that long and has good pictures of the movements that were used for repeated movement testing. But we can start. So basically it's addressing today whether or not it's an elbow joint derangement. So something in that joint is not moving well, and we have hypothetical reasons as to why that might be or what exactly is happening in the joint. But for now, we can just say the joint's not moving well and it's creating signs and symptoms. Or is it a tennis elbow? Is it what we also call lateral epicondylgia or wrist extensor tendinopathy? So pain on the outer part of the elbow is where that tendon is. The study is called The Application of Mechanical Diagnosis and Therapy in Lateral Epicondylgia. Joseph Mascio and several others published this study in 2016. And mechanical diagnosis and therapy is a mouthful. We call it MDT. It's also known as the McKenzie method. But what I want people to understand is, though I think when someone says McKenzie method, it sounds a little bit overwhelming, like you have to learn an entire new method, which is kind of true, but we can just parse it down to the minimum, which is repeated movement testing. Learn how to do repeated movement testing on yourself or with your patients, and then you're on your way to understanding this framework of joints, which is not really provided to us in school, where the focus is more, at least my schooling was a lot on tendons and muscles. So patient requirements: that the lateral epicondylgia special tests produce pain of 3 or more and were positive in 2 or more of the tests that clinicians commonly use to see if it's a tendon problem. So gripping, palpation of the proximal wrist extensors, resisted wrist extension, resisted finger extension, and stretching those extensors, putting the wrist into flexion or some flexion and a rotation. So those had to be present, and those in mainstream orthopedics, you have those, you have a tendon problem. And this study looks at specifically 3 patients who met those criteria. So criteria that would make the average or mainstream taught clinician think, oh, you definitely have a tendon problem. Mascio and his colleagues were putting that question to the test. So they looked at the spine, because we do see a decent amount of patients who present with elbow signs and symptoms that are resolved with moving the spine joints into a specific direction. So they did their spinal repeated movement testing, and if the patient's signs and symptoms were affected by movements of the neck or mid-back, they were not included in this study. So that's an important piece to note, because I do see patients who have local elbow stuff that is fixed with moving the spine. So the outcomes they looked at was the pain scale, percent improvement, and the upper extremity functional scale, which is a questionnaire about how someone's functioning. So I've written out 2 of the 3 patients. I ran out of room, and I don't want to make these videos super long. So 57-year-old female, intermittent pain in the elbow for 6 months, no apparent reason for why it started, average pain of 6 out of 10, and an upper extremity functional scale of 68 out of 80. So to note in this part is that she doesn't attribute a reason to it. And as I've said before, for most tendinopathies, I am expecting to hear in the history like something changed. I started playing tennis, or I moved my keyboard around, something that is spurring the pain because it created an overload to the tendon, and that's what created the tendinopathy. Not all, but most. That's one thing I'm listening for in the specific verbal history, is that something was changed to provoke that tendon. So she's worse with gripping, lots of mid-range pronation and supination of the forearm, and exercise class. So when we hear that the patient's symptoms are provoked with mid-range movements, that also doesn't make me think it's a tendon, because the tendon's going to be provoked when it's asked to work in a load that it can't, and mid-range movements aren't that much of a load that aren't resisted. Baselines in the clinic. So again, we're looking for 2 or more of the typical tendinopathy baselines to be positive. Baselines were positive for gripping pain, palpation pain, stretching the extensors pain. But then we also look at the other orthopedic baselines, right? We just don't do quick tests. Minimal loss of elbow flexion with end range pain, ERP, and a minimal loss of extension without pain. So this is also where, if I were doing the exam, I would start to question, is this a joint and not a tendon? Because I would not expect there to be loss of extension, especially without pain. Because if the tendon were so provocative that there was a loss of range of motion, it would be because of some pain going into that area usually. And minimal loss of flexion, I mean, it could be because that tendon's on stretch, but I don't see a lot of range of motion loss when it's truly a tendon problem. And pain at rest was her other baseline in the office. So the clinicians looked at repeated loaded elbow extension with overpressure. So that's typically the arm like this, supported on the table or the back of a chair, and pushing from some flexion into end range extension. As simple as that. And loaded means that there's some patient's weight through that upper extremity. Overpressure, using the other hand, pushing that elbow into end range extension. They did a few sets of those and reassess the baselines. That's what repeated movement testing is, right? So if you didn't do repeated movement testing as part of your orthopedic evaluation, you would find these things and you would probably conclude it's a tendinopathy and you would start your treatment. My exam doesn't end there. For nearly all patients, we're doing repeated movement testing, which is the backbone of MDT. So repeated movement testing, you do the movement, you reassess those baselines. They reassessed the baselines and they were better, so that became the home program. Do repeated loaded elbow extension with overpressure, approximately 10 every 2 hours or so. The patient came back and was better, so they didn't change the loading strategy. They didn't change the home exercise. And over 10 days and 3 visits, she went to having no baselines, nothing problematic in the office, 0 pain, noting 100% improvement, and an 80 out of 80 on that scale. And they did a phone call at 3 months and she said she was still good. They did a phone call at 12 months. She said, every few months I'll get a bit of that familiar pain. I'll do the exercise for a few sets and it'll go away, and I'm content with that being how I address this. Patient number 2, and I will say patient number 2 and 3, what sets them apart from patient number 1 is they came to the Massio's clinic with a diagnosis from a primary physician of lateral epicondylgia. So that factors into a lot of things. If patients think that the other diagnosis is correct and they're not amenable to a different diagnosis, it can provide a little friction. I will say that you want someone who has expertise in orthopedics to ultimately be the diagnosis maker in most cases versus someone who's not experienced with orthopedics. So these two, patients 2 and 3, already had that diagnosis when they arrived. So he's a 75-year-old male, intermittent pain in the elbow for 4 months. He associated it with doing a lot of wood cutting, so that makes sense for a tendinopathy. Average pain of 5 out of 10. The scale was 73 out of 80. He reported being worse with heavy lifting, shoveling, and exercises that involved flexion and extension of the elbow. In the office, the baselines, again, we're looking for at least 2 of them to be positive that would indicate a tendinopathy. Positive for gripping pain, palpation pain, resisted wrist and finger extension was painful. But then when you look at the range of motion baselines, minimal loss of extension with pain at the end range and pain at the end range of flexion. So again, minimal loss of extension makes me start to question, is this a joint problem instead? So they looked at repeated loaded elbow extension with overpressure, just like with patient 1, and he got better. So they sent him home with that, since the baselines were improving with 20 or 30 or 40 reps in the office. They sent him home with that. He came back 3 days later, reported being 50% improved overall. They looked at more of that same movement, and it didn't seem to have a continued benefit on the baselines. So they also looked at force progression, so more force into that motion with loaded elbow extension. It wasn't helpful. They looked at flexion of the elbow in the sagittal plane, not fruitful there either. I think they looked at flexion for this patient. I might be wrong. It might have been patient 3. But then they looked at repeated loaded extension, but this time with the forearm in pronation with wrist flexion. So it's an elbow extension, but in a different position in terms of rotation. And the patient went away, came back a few days later, reported 70% better. They again looked to see if that exercise was still the best exercise for this patient to invest his time in several times, or 6 to 8 times plus per day. They deemed that it was. He came back about a week later, 90% improved. Another week later, 100% improved. So ultimately at home, he was only doing 2 different forms of elbow extension over those 18 days. At 18 days, he was 100% resolved, no pain, 79 out of 80 on the scale. And again, phone calls at 3 months and 12 months, he said he was doing well. So I'm not going to go into patient 3 today. You can definitely take a look at it. It's a little bit of an outlier in terms of he did get over 50% better with repeated movements at home. And then after they cleared that joint problem, they did several weeks to over a month of some, what I would deem the efficient tendinopathy treatment, which is loading that tendon into the provocative motion repeatedly throughout the day. And then he eventually got to where he was, doing well. But it was a longer course because tendinopathies can respond more slowly. So after the joint was attacked or addressed, they started to address the wrist extensor tendon, and that took a longer course to get better. So I hope this is clear. It's hard to make clear to patients who don't, or clinicians who don't know what repeated movement testing is. But again, take your baselines, do the movement, retest the baselines. And when you use cause and effect, you can verify to yourself that this is not kind of these ethereal ideas, or that they're based on a lot of like hocus pocus manual therapy, because these patients, they may have had some manual therapy to add some overpressure in the clinic, but the hands that were applied to the elbow were not manual therapy per se. They were more like using those hands for assessment. I think we're missing a lot of patients who have joint problems, and they're being called tendon problems. And this is borne out in the literature. If you look at the literature for how people do with lateral epicondylgia, it's not excellent. A lot of these patients continue to have elbow pain or recurrent elbow pain. And so hopefully I'm trying to get the message out more and more that if we add repeated movement testing to our orthopedic mindset and framing of how the body works, and therefore implement it in the office, or if you buy the books and you implement it at home, then you'll start to understand that a lot of our problems in orthopedics are just joints that are tweaked, so to speak, and need to move in a specific direction to get better.